Dr. Bell, seja bem-vindo, que alegria tê-lo aqui conosco. Eu gostaria de iniciar, se me permite, citando uma pequena frase em Asas sobre o Desejo, de Wim Wenders. Ele diz: deixe-me entrar na história do mundo, nem que seja para segurar uma maçã. Na minha opinião, nós aqui hoje estamos segurando uma maçã. Estamos entrando para a história do mundo, um pedacinho pequeno do mundo, no sentido de trazer uma palestra de muita importância para questões da saúde física e mental de crianças e adolescentes, trazendo a ciência, a história, a experiência, para esclarecer um assunto tão sério e de tanta gravidade. Então, é com muita alegria que recebemos hoje o Dr. David Bell e também o Dr. Paulo Ceccarelli para falar sobre os sofrimentos de gênero na infância e na adolescência. A palestra de Dr. Bell, First, do not harm. Primeiro, não cause dano. Dr. David Bell é ex-presidente da Sociedade Britânica de Psicanálise. Aposentou-se em 2021, após 25 anos na Tavistock, onde desenvolveu e liderou um serviço especializado para pacientes com distúrbios mais graves. Ele lecionou e publicou teoria psicanalítica, a obra de Freud, Klein e Bion. Ao longo de sua carreira, esteve profundamente envolvido em estudos interdisciplinares, psicanálise, literatura, filosofia e teoria sociopolítica, e é um dos principais especialistas psiquiátricos em imigração, asilo e direitos humanos. Em 2018, escreveu um relatório sobre o serviço de gênero para crianças e adolescentes, o GIDS, no Tavistock, processo que levou à Case Review, a revisão mais minuciosa e extensa do tratamento de crianças com distúrbios relacionados ao gênero e, eventualmente, ao fechamento do GIDS. Ele continua envolvido no debate, buscando manter uma perspectiva reflexiva e psicanalítica em um clima altamente tóxico e politizado. Publicou artigos e proferiu diversas palestras sobre o tema. Atualmente, ministra regularmente cursos online sobre o desenvolvimento da psicanálise e cultura. Com a palavra, o Dr. David Bell.
Então, muito obrigado. Estou muito honorado em ser convidado para falar consigo hoje. Falo pouco português e não é possível falar o papel, a jornada em português, mas queria, pelo menos, começar em sua língua para fazer um vínculo. Eu trabalhava muitos anos atrás, muitos anos atrás, eu trabalhava em Moçambique e assim aprendi português. Durante o tempo do fim do colonialismo em Moçambique, o governo de Frelimo estava a começar. E gosto muito da língua, é bom haver a possibilidade de falar. Mas agora vou ler my paper in English. So my paper is called First, Do No Harm. And the paper, I wrote a paper in 2021. And this paper is a kind of postscript, a kind of follow-up, because after my paper was published, there were various comments made, some constructive, some less constructive, but it also enabled me to think a little more. But I'm going to start kind of at the beginning. But before I say anything, I want to make a general statement. And that is that all psychiatric, psychological, and I mean all psychiatric, psychological illness takes place on the boundary between an individual and the culture they're in. No psychiatric illness is completely internal, and no psychiatric illness is completely external. And because cultural conditions change, the way that psychological problems express themselves changes. And that's one of the ways that our subject is very different to physical medicine. Pneumonia is pneumonia, whether it's Victorian Britain or a modern Brazilian culture, it's still pneumonia. That's not the same for psychological disturbance. So over a period in 2018, I was working at the Tavistock, and I was part of an organization or committee called the Council of Governors. I was the staff representative. And in 2018, staff working on GIDS came to talk to me. GIDS is the Tavistock Gender Identity Development Service. They sought me out as their representative because they had profound concerns as to the way the children or young people were being mismanaged and harmed within the GIDS service. All except one, so it was about 10 people who came to see me. All except one would not see me in my room at the Tavistock, and instead were interviewed at my private room. They felt too frightened to come and talk to me in my room at the Tavistock. They thought they would be found out and be accused of talking to me, who was regarded perhaps as an enemy, and that they would be told they were transphobic. That his thoughtful engagement was treated as an enemy. This is a familiar experience for clinicians working in gender services. This intolerance of doubt and thought that characterizes certain kinds of mental states, and we're familiar with that, here leaks out and becomes a force in the social realm. You shall not criticize, you shall not doubt. This reflects a wide cultural transformation which has affected many discourses. In English, sometimes referred to as cancel culture, a world of a peculiar binary. That is, if you're not with us, you're against us. That is, it is a paranoid universe, a world where there is no room for a mind that wants to think about things. The GIDS story is as a microcosm of the deterioration in intellectual freedom that has become a cultural international phenomenon. The complete unacceptability of an alternative or critical thinking was, of course, something quite foreign to the atmosphere of the Tavistock. The staff all raised very similar issues. They, now if you could perhaps show the slide now. That's possible.
Just a moment.
Thank you very much. The slide shows the increase in referrals to the Tavistock, which was the National Service for Gender Difficulties in Children, over a period of about 10 years. And it starts with about 60 or 70 referrals and ends up with, I think, about 3,500. Now, you only have to look at the slide on the left. That's for the United Kingdom. And it looks rather complicated, but it isn't really that complicated. The most important thing to see is on the far left, 2010, number of referrals, maybe about 40. 2021, number of referrals, 5,000. The other thing is to look at the green. The green is the number of referrals who are girls between 12 and 17. And you see the huge increase. At the beginning, boys were a bit more than girls. And then this rapid increase in girls, to eventually girls become about 70 to 80% of all referrals. Okay, you can take the slide down now. Now, the extraordinary thing that there should be such a massive increase and no inquiry as to what underlay these phenomena. But of course, it's reasonable to assume that poorly understood social and cultural factors are involved. Clinicians were also carrying huge caseloads of up to 140 cases. The service had what's called a trans-affirmative position. That is an unquestioning acceptance of the declared gender identity of their child patients. That was extremely difficult to question. This is a unique phenomenon. Never before in the history of psychiatry or child psychiatry has it ever been stated that a physician's job is to agree with their patient. A physician's job is to understand, to think, to question, to help, but it is not just to say, I agree with what you say. There was an inappropriate involvement in the service of highly ideological motivated trans organizations. Very inexperienced staff were dealing with the cases, high levels of stress and turnover. There were serious ethical issues as regards the inadequacy of consent, often with very little discussion of the already known potential brain, cognitive and bone complications and the potential for infertility and sexual dysfunction that can ensue from puberty blockers and then opposite sex hormones. Very little capacity to resist the pressures to transition children. A very peculiar simplistic approach. I was told that certain cases were viewed as straightforward. I was told this by a senior clinician in the service. She told me some of the cases are straightforward. And puberty blockers could be prescribed after one meeting or two meetings. How a child with gender distress seeking medical and surgical intervention could be thought of as straightforward was, of course, very concerning. It also come to our attention that of those who started on puberty blockers, 98% stayed on them and went on to opposite sex hormones. So starting child on puberty blockers was not a pause for thought. It was in effect starting them on a road to opposite sex hormones and probably towards surgery. So the decision to commence puberty blockers is freighted with that knowledge. There were concerns about the very low level of clinical engagement. And one of the problems was that GIDS was viewed as a conduit to medical transition. So children would arrive with nearly identical rehearsed scripts. That is, they were saying what they thought was necessary to tick all the boxes to be started on the pathway. Obviously, it would take considerable time, sensitivity, maturity of the clinician to get past this kind of automatic defense. And time was what they did not have. And perhaps one of the most important was many of these children were confused, not necessarily about gender, but about sex, about their sexual orientation. But sexuality was not even taught on the GIDS service. Everything was seen in terms of gender. And some of the clinicians who came and talked to me were gay and lesbian themselves. And they were very worried that these children were really confused about their sexuality. But when they raised this, they were taken off the cases. And when they raised, for example, the problem of homophobia in families, the clinicians were taken off the cases. Finally, and perhaps most disturbing of all, the various serious psychological problems affecting these children were being neglected. And further, they were being placed on treatments for which there was no evidence. That no child on GIDS, given this experimental treatment, was followed up. So no one knew what happened. Parents who raised doubts about their children, who were concerned about the advisability of them starting a medical pathway, were often alienated from the service or pressured to accept the child's position, or were told they were transphobic. Thus, the historical knowledge that these parents carried, so vital for a thorough assessment of, for example, past trauma, confusions about sexuality, histories of anorexia, all this was therefore excluded from the assessment of the child. It rapidly became clear that GIDS existed in a peculiar position, almost completely detached from the Tavistock culture. Senior staff on the service were largely hostile and mocking of notions of the unconscious and of psychoanalysis. Almost over its entire history, the Tavistock has had to manage often fierce internal debate and hostility to psychoanalysis. And overall, I think this has been often difficult to manage, but growth promoting. But now that hostility acquired a home, as one of the staff put it to me, GIDS is a kind of parasite growing inside the body of the Tavistock, feeding off its resources, a parasite that will grow and possibly destroy its host. Around this time, a number of parents and adolescents contacted the Tavistock, raising rather similar issues to what I raised in my report. And they were ignored. My report and its subsequent received a lot of publicity because it was leaked to the press. Management ignored my report. They set up a review within the Tavistock, which merely rubber-stamped what was already being carried out on GIDS. What we call in English a whitewashing. But my report was leaked to the press, and then there is increasing public concern in the public, among members of parliament and so on, and led to increasing critical understanding of the inappropriate treatment of gender distress in children. Note, I say gender distress. I do not talk about transgender in children, nor do I use the word gender dysphoria. Gender dysphoria is just is a meaningless term. It's just a redescription in Latin of gender distress. So why not just say gender distress? Legal action was taken by an ex-patient and a parent, seeking guidance from the court as to whether or not children were legally in a position to give consent to medical intervention whose long-term consequences were unknown, but for which there was already concerns of potential serious damage. More than concerns, known serious damage. Central concerns in these proceedings related to whether the child's level of maturity and the presence of very severe psychological disturbance would interfere with their capacity to make a reasoned consent. The judge delivered the judgment in 2020 and found that children were not in a position to give consent. But as important, the judges expressed very serious concerns about the poor clinical management of GIDS. They were astonished that there were no records of how many children went on to opposite sex hormones. They were astonished there was very little record of what happened to the children. And they were astonished there was very little record of the number of other disorders the children were suffering from, such as autism, for example. About 35% of the girls were on the autistic spectrum. Sonia Appleby, the child safeguarding lead for the entire Tavistock, was intimidated for being concerned about what was happening to these children, and was successful in an action against the Tavistock, taking action against the Tavistock for undermining her capacity to protect her patients. This judgment supported the claims of staff regarding the atmosphere of threat and intimidation directed towards staff who raised concerns. In response to these concerns, the government, via NHS England, set up a wide-ranging review of clinical guidelines, known as the CAS review. This is the most thorough review of treatment of gender distress in children and young people ever undertaken anywhere in the world, and its findings gave very substantial support to the concerns that I had raised. In particular, it was critical of the affirmative model, describing it as an inappropriate clinical stance. It was critical of the prescription of puberty blockers with no evidence base. And it was very critical of the sidelining of the children's other serious problems. Hilary Cass, the expression she used was diagnostic overshadowing. That is, that once the diagnosis, I put it in inverted commas because it's not a diagnosis, but once a diagnosis of transgender was made, everything was seen through that lens. So everything was to do with transgender. So all the children's other problems about anxiety, personality problems, histories of trauma, sexual confusions, all of it was now seen through this distorting lens. Similar moves to one of the words I use is de-exceptionalize. That is that the young patients were treated exceptionally. They weren't treated according to ordinary clinical ideas. And so similar moves to de-exceptionalize, that is to normalize treatment for gender-related distress in children and young people, are occurring in many other countries in Europe. So that completes some of the background. The 2020... Is that okay? Não entendi. Está problema?
Sorry, you can go on. Sorry.
Oh, obrigado. The 2021 paper might be thought of as just addressing two distinct issues. One is the failure of clinical governance at the Tavistock, and the other is to do with my critique of the ideological position. But of course, these two matters are intimately related. That is, the penetration of gender ideology into the clinical service acted as a powerful group force, obstructing the capacity for ordinary clinical reflective thinking. This is particularly demonstrated by the fact that those who raised concerns were treated as enemies, and attempts were made to silence them. The same pattern very common in many countries in Europe and America. I think there would be broad agreement amongst psychoanalysts that it is an essential part of the work to endure states of not knowing. Affirmation acts exactly in the opposite direction. Agreeing with a child that she is of the opposite gender forecloses further exploration and understanding, is not only non-analytic, but anti-analytic. This foreclosure has been promoted by the capture of clinical services, resulting in a pronounced tendency to underplay the seriousness and complications of medical and surgical interventions. We even see a peculiar Orwellian newspeak, where patients and even their clinicians talk of top and bottom surgery, instead of surgical castration, penile amputation, removal of pelvic organs, and fashioning of pseudo-organs out of other parts of the body. Hence the title of my paper, First Do No Harm. In the United Kingdom, trans lobbies had a huge impact upon leaders in education, government, and health settings. And it remains common in schools, even now, for children who express their difficulties through declaring they are trans to be celebrated as coming out, and staff and students called upon to change pronouns straight away and accept the child is really of the other sex, a delusional idea. This in turn unleashes powerful group forces within the school, the peer group, and elsewhere, particularly online, which makes the child extremely wary of reconsidering their new identity, which is then experienced as a betrayal. So huge forces to keep the child in that position. This attitude has been overturned by government policy, but it's taking a long time for that policy to have any impact on schools. As Cass points out, social transition, which is what I'm describing in schools, is not a neutral act, but is a clinical phenomenon, a clinical act, and therefore teachers do not have the authority to embark on social transition with a child because they do not have the knowledge to make an assessment. So it's not a neutral act, it's one that has serious long-term consequences. The sex body can to some extent be denied until puberty, but puberty onset brings a terrifying collapse of that denial and often then the demand for puberty blockers. It is vital to differentiate gender distress from transgender. The former refers to deep feelings of discomfort with the sexual body and has multiple sources and multiple appropriate therapeutic approaches. Services pressured by trans lobbies are pressured to use the term transgender. I think I would put it more strongly and say you should never use the word transgender in a child, because that is closing things down. You should use the term feeling distressed in relation to their gender, and we don't know what this means, and it's going to take a long time to find out. A slightly more philosophical way of putting it is we want to understand the nature of it is a kind of developmental view. The child is transgender is a bizarre essentialist view. Some people have stated clearly that they believe that some of the youth who suffer from gender distress are really transgender. Do they mean the ones who continue into their 20s to maintain this belief? I will come back to this later. Although many of the issues I have raised are based on my experience at the Tavistock, it's a worldwide problem. And I've discussed with many colleagues from European countries, from America, from Australia, and particularly the USA, make it clear that clinicians have very great difficulty in raising concerns and are often silenced. The profound role of social influence. This comes back to what I said about at the beginning. Some have tried to discount the profound role of social influence in the several 1,000% rise in children identifying as being transgender. And they see this as resulted from greater social openness. Were that to be a plausible explanation, we would expect a roughly similar number of boys and girls, and a roughly similar number, though not necessarily identical, increase across age groups. Instead, what we have seen is that the vast majority of the affected children, young people are adolescents and young adults, and the overwhelming number are females. The field owes a great debt of gratitude to the work of Littman and her pioneering work on social contagion. She published a paper that for the first time described the phenomenon of social contagion in teenage girls. They're a very special group for social contagion. This became known as rapid onset gender distress. Clinicians at nearly every gender clinic in the world have published on this subject. That is, a sudden increase in the number of rapid onset gender dysphoria. These include UK, Canada, Finland, Holland, Denmark. Now, some people object to the notion of social contagion, and why they do so is most puzzling. For we have long known that social and peer contagion have a very important part to play in the incidence and phenomenology of psychological disorder. That's widely accepted. Freud described epidemics of hysteria in girls' boarding schools. Some of you may remember that. He describes a girl of, I think, about 15 getting a letter from her lover and he's leaving her, and she faints. And there's an outbreak of fainting in the school. Freud rather wisely points out that they're all saying through their fainting episode, I too have had sexual experience, but they repress the wish to announce this, and they do it through this mysterious identification of fainting. Anorexia is known to be socially contagious. Recently, there was a sudden rapid increase in individuals developing Tourette-like tics following exposure on TikTok of individuals with Tourette syndrome. So it seems to me self-evident that every psychological disorder, as I said, expresses this complex interaction between the individual and the culture she finds herself in. Changes in cultural context will inevitably affect how individuals present with their problems. To come back to anorexia, before the 1990s, anorexia was almost unknown in Hong Kong. Then, following the very public death of a young anorexic woman who appeared in a marketplace, weighing about 4.5 stone, then died, the condition emerged as a new phenomenon. And then gradually over the years, its prevalence increased. Mentioning anorexia in this context is particularly fitting, as I've spoken to quite a number of women who underwent medical and surgical intervention, who had been anorexic earlier in their lives. Looking back, they were somewhat shocked that no clinician had ever made the connection between anorexia and gender distress. As one of these young women put it to me, aren't both directly related to hatred of the sexual body? She wasn't a clinician, but she was amazed that no clinician had made that connection. I could go on, but my main point here is that the idea of social contagion has a long history in the understanding of psychological disorder. It's complex, and it's an umbrella term. Girls seem to be much more susceptible than boys. Certain individuals, perhaps those with long-term difficulties or problems, those who are alone and rather lost in the world, are particularly susceptible to social contagion and picking up online or from colleagues or even from families that all their problems can be explained by gender. Further, the effects of social contagion we might reasonably expect to be greatly magnified in our digital age. Lastly, we might expect the disposition to social contagion to be more powerful when there is the appearance of a new disorder which attracts a great deal of public attention. It becomes a kind of huge cultural drama, and that in itself is an important phenomenon leading to more cases. So if one were to discount social contagion, there would need to be an explanation of why social contagion is to be denied an important role in understanding the etiology of this problem. That is, it seems to be an example of a strong tendency, again, towards exceptionalizing gender identity, to making exceptionalizing from the ordinary, common sense, and not so common sense clinical understandings of children, and ordinary explanatory frameworks. In the JID service, and this was reflected around the world, there was a complete absence or very minimal presence of consideration of sexuality. Of course, from a psychoanalytic perspective, sexuality and gender are completely intertwined. Confusions about sexuality is an important causal route to gender identity disturbance. It isn't uncommon, for example, for a gay boy to think that because he's attracted to same sex, maybe he's really a girl, or a girl who's attracted to a girl. Of course, it's very common for girls to develop a crush, to become sexually excited, particularly about older girls, and that's often a passing phase. For others, it'll be the beginning of their development as a lesbian woman, but it certainly is not to be taken as indicative of being transgender. Some children who show characteristics of being gay or lesbian find it's not tolerated by their family, often very overtly, but equally often in a more subtle and even unconscious ways. The children internalize this intolerance of their sexual orientation, which then becomes manifest as hatred of their own sexual body. There's considerable evidence that a large number of these children, if helped in a proper manner, desist from transition and develop into gay or lesbian adults. In the light of this, gay and lesbian communities in the UK, and in my view rightly, see this casual affirmation of often confused young people as transgender and putting them on a medical or surgical pathway. They see it as a form of conversion therapy. The data is limited. There have been no proper follow-ups comparing groups who were affirmed and started on a medical pathway. We need to bear in mind that detransitioners, that's young people who change their minds, many who've emerged as gay and lesbian, many of them emerging as lesbian women, and many of them emerging as gender non-conforming women. They're not the stereotype of a gender. They tend to understand, those who realize they were let down and they weren't transgender do not return to clinics that affirm them. And so there is no record of failed treatments. I was once told by someone at the Tavistock that the number of failures was somewhere below 0.5%. But how could they know that when they never followed them up? What they meant was those were the numbers that came back. But I learned from the patients I met that they don't go back to the Tavistock. Medical gender transition involves irreversible physical changes leading to infertility and sterility, with no established ways of preserving fertility, and carries a number of known and yet as yet unknown risks. The kind of risks we're talking about, we know about bone mineralization, effects upon the brain. We're beginning to learn about cardiovascular effects. And given that we cannot predict which of the young people will change their minds, indicate the need for extreme caution, which is the point of my paper. Now, some clinicians, and I came across this at the Tavistock, refer to reversibility of puberty blockers, by which they mean that when they are stopped, puberty commences. This is a very serious misrepresentation. The body and mind of a child is not like a video recorder, where you can press the pause button and then 3 years later press play. There's been increasing concern as to the consequences for bone mineralization and brain development. There's good neuropsychological evidence that delaying puberty interferes with a critical period in brain development. The child's psychology and the psychosocial world in which they function are ready for puberty at the appropriate age, say, 10, 11. Pausing puberty and recommencing some years later means the child is embarking on puberty in a different biological state, in a different psychological state, in a different psychosocial state. But in any case, as I've said, given that nearly 100% of children who go on puberty blockers stay on them, and go on to opposite sex hormones makes even these false claims of reversibility irrelevant. Of course, as you probably know, NHS England stopped the prescription of puberty blockers for children. It has been suggested that the concerns that I and others have raised are somewhere a departure from an analytic perspective. So I think it might be helpful to unpack a little what we mean by psychoanalytic perspective. To my mind, this has three different aspects, all related. One is non-specific. This refers to psychoanalysis being part of what I call a mode of thinking, which we share with other disciplines, that looks beneath the surface. Think of sociology, anthropology, history. Recognizes the degree of complexity of the phenomenon and their multi-layered determinants. Views an individual's subjectivity and behavior as determined by forces that act beyond consciousness, these deriving from internal and external sources, including group and social pressures. So that's rather general. Then more specifically, we can think of a psychoanalytic model of the mind. And perhaps the best way to illustrate this is to give one possible way of thinking about gender conflicts in some children and adolescents. This is not meant to be a case study, just a model that might help us think. It is fairly common that prepubertal girls have an intense unease, even disgust, of any sexual feelings they detect within themselves. It would be natural in such circumstances to experience a need to be rid of these thoughts and feelings, to get rid of them. And of course, the mother is a suitable projective target. It is, so to speak, she who has all these terrible and disgusting sexual thoughts, not me, my disgusting mother. However, in such circumstances, the onset of puberty can be quite terrifying. Witnessing the changes in the body can be felt as a kind of return of the repressed, or perhaps better, a forcible reintrojection of what was projected. Some girls even report that changes in their bodies make them feel as if they've been taken over by a strange alien force. Of course, we might call that force mother. When we think of this as experiencing mother's body as entering and taking control. Such situations in a different cultural context may be managed and so pass. But in the current context, they are massively amplified by the cultural toxicity, cultural situation, and given a peculiar substance. And the belief, I am in the wrong body, and so I have to be rid of this body and enter another body, the body in which I belong. Some of the trans organizations used to say that the child was in the wrong body. They've stopped saying that now because I think they fear legal action being taken against them for saying that. Many children and young people presenting with gender difficulties are gripped more than anything by the urgent need to be rid of their sexual body, to get out of it. And then the clinicians working in the services claim to be able to make that a reality. So here we use familiar psychoanalytic terms, projection, introjection, identification. And it is worth perhaps adding that these young people in this kind of mental state are unlikely to be able to think reflectively about the consequences for their lives in the distant future, what it might be like to be infertile, anorgasmic, or to have the risk of major surgical complications. They just want out. The apparently liberal approach, which many appear to espouse, is a profound failure of safeguarding. Then we use the term psychoanalytic to refer to the context of what goes on in a psychoanalytic session, and we think of our concepts such as transference and countertransference and so on. But the context that I'm describing is not of ongoing analytic work. This is a context for children who are seen between 2 and 6 times, a decision made, and then put on an irreversible medical pathway. This makes the adoption of a proper psychoanalytic attitude really an impossibility. And sometimes taking a psychoanalytic attitude is termed being transphobic. That is, to being open, not affirming. I do think that at a group and institution level, individual clinicians might be caught up in a rather manic process, where they are pressured to quickly share the patient's view that their problems will be solved once they undergo medical and surgical procedures to alter their body. This manic process, which brings an abandonment of thought, is supported by the penetration of gender ideology into clinical services. This external pressure will, in many cases, form an unholy alliance with the pressures coming from the patients and sometimes from their families. Some of the clinicians told me that they would hear the parents coaching the child in the waiting room. When they ask you, how long have you had this? Say you've had it since you were 3. When they ask you, it doesn't matter what, they're just coaching them to give the right answers. In a more appropriate clinical setting, of course, that a clinician would be supported in their capacity to resist the pressure coming from the patient. That is, if they've confined themselves in an external context where there's a balanced perspective. The mere act of seeking to understand the underlying narrative of young people who develop gender conflicts is often met with hostility and accusation, even seen as interfering with the patient's liberty. So being alarmed at the possibility of a confused and disturbed adolescent embarking on irreversible transition is, I believe, an appropriate response to the current situation, where large numbers of young people have been placed on a pathway which has irreversible long-term consequences, with the lack of any evidence to support it, and where there's a real basis for concern about long-term harm. The CAS review is largely consistent with the psychoanalytic attitude. The review emphasized that these children with multiple problems have multiple problems. Just to give you another example, one of the clinicians told me about a child 2 years before, the older brother had been killed in a road accident, and the parents were in a state of frozen grief. And the younger child, a girl, announced that she's in the wrong body, that she's really a boy. Now, you wouldn't have to be a great psychoanalyst to think maybe she wants to give the dead brother back to her parents. Maybe she thinks he was the preferred child. But that was not even explored. So the review emphasized that these children with multiple problems and viewing all these difficulties through the simplifying lens of being trans has caused considerable harm to generations of children. As I said, there was no follow-up and no records of the other difficulties that children had. Other difficulties that children have, such as anxiety disorder, histories of trauma, depression, being alone and isolated, autism, and so on, are often referred to as comorbidities. And that might be a reasonable term for autism or neurodevelopmental disorders. But in other contexts, it is the wrong expression. It's not a comorbidity. For problems such as depression, conflicts over sexuality, profound family problems, anxiety, histories of trauma are not comorbidities. They're part of the whole problem. As Freud pointed out, one cannot have 2 neuroses or 2 or more neuroses. Everything is connected to everything else. He likened trying to think of there's one neurosis separate from another would be like trying to being a midwife and trying to deliver only part of a baby. That is, the neurosis is the whole person. Conclusion. I see the emergence of distress in relation to gender as a complex and multifactorial, and a condition that has become exponentially more prevalent as a result of social context. Now, I haven't described that much in this paper. I have talked about it elsewhere, But I do think that misogyny, increasing misogyny, is very important. The huge number of girls who start identifying as boys. I think a culture where there's a commoditization of the body turned into a commodity, a culture where there's little respect for the pursuit of truthfulness and so on, are all relevant, and of course the digital age. As I think we have made clear, thoughtful engagement is treated as a kind of enemy, and this is certainly the experience of many clinicians. The wish to think over things and to understand them, or why a child has developed gender distress, or why they're expressing their problems through that label, can be seen as transphobia. That creates a paranoid universe, where you're either with us or you're against us. We do need to recognize that transphobia for our community, I mean the psychoanalytic and psychiatric community, has an unfortunate resonance, namely the homophobia that is part of our history. I have in mind the dark history of conversion therapies for homosexuals, particularly, although not only, in the United States. I believe a fear of repeating this has interfered with the capacity to distinguish between conversion therapy and a wish to think about things. As I see it, the rapid decision as regards the provision of medical and surgical intervention is itself a form of conversion therapy. Like the past so-called treatments for homosexuality, it seeks to refashion the body as the only permissible solution to conflicts about gender. It brings about transformations in the body, converting it in order to satisfy insufficiently understood and examined individual, family, and social agendas. It is sometimes stated that we may harm some children by not putting them on the medical pathway. That is, in the end, they persist into their 20s with their sense that they need to undergo transition, to alter their body. So it will be said, they've had to live, from 11 to 21 with all that suffering. Couldn't we have stopped it? We've made them suffer. But the answer to that is really quite simple. In any population of children and young people who present with gender distress, there are two groups of children, Group A and Group B. Group A will persist with with gender dysphoria, gender distress, and they will eventually in their 20s seek medical and surgical intervention. Group B, who with sufficient appropriate neutral support will change their minds, they will desist. That is, they'll accept their natal biological sex and often develop into non-conforming gay and lesbian adults. But given the complete lack of evidence, we have no way of determining which group any particular child belongs to. There's no way of knowing. So that means you can't, given that knowledge, you cannot, there's no way it could be right to put any child on the medical pathway. Yet given this knowledge, many centres still continue to risk doing irreparable damage to children by falsely claiming procedures are reversible. Good, I knew, just looking. Finally, I want to say something about the sort of cultural atmosphere. The possession of a particular identity, in terms of how much identity has become part of the cultural world we live in. Of course, it can be extremely progressive and helpful, but it can also be regressive. The possession of a particular identity can be taken as supplying one with a peculiar kind of higher authority. If, for example, a person says, as a gay man or a Jewish man or a disabled man or a black woman, it would be reasonable to accept that such a person, because of their specific experiences, will be able to enrich any discussion of the world in which they identify. But this does not bring entitlement to an unquestioned higher authority. That is, belonging to X group or to Y group, my views as to what is true of the world, particularly about the group to which I belong, remain as open to question as the views of any other person. This assumed higher authority can exhibit a kind of entitlement, an entitlement not to be questioned. a demand to be exempt from the ordinary canons of what is to count as good judgment. There can be no personal or group sovereignty over what is to count as true. There is, I believe, a link to the more generalized undermining of truth value that is characteristic of our age. One wonders if the peculiar intransigence of these beliefs might at times be a result of the awareness of doubt, a doubt that is disowned and projected into the other, who must then be silenced. If we take it as a fact that gender identity is largely, though not only, socially constructed, then there is a peculiar paradox at the heart of this phenomenon. The apparent freedom and liberation it expresses is totally undermined by advocating all possibility of change, not in the fluidity of the mind, but the material alteration of the body. As I see it, there's been a peculiar regression in thinking. In our contemporary, at least urban and liberal worlds, we're generally tolerant. We even celebrate a certain kind of gender fluidity, the way that people might express their gender and sexuality. We, that more liberal-minded community, are not really that interested who a person, if we make appointment to a committee or to a job, we're not interested in who the person goes to bed with. We're less bothered by a man being a bit what someone might used to call camp, or woman being somewhat unfeminine. Why should that interest us? This exists alongside a toleration of certain limitations arising from the body. But in the ideology of the militant trans lobbies, there's a peculiar rigidity of gender identity, coupled with a belief in the total fluidity of the body. This is coupled with a peculiar essentialist mode of thought. Gender identity is confused as anatomical sex, and so is seen as biological and fixed, rather than psychological, social, and fluid. What I mean is, of course, is that if a young child, a girl, wants to play with train sets, or a boy is interested in dolls' houses, that should be part of fluidity. But in the more binary world of the trans movement, if a boy isn't a proper boy, then maybe he's a girl. And if a girl isn't a pink dolly girl, liking her dollies, then maybe she's not a girl. That's what I mean by the regression. B. Campbell, a well-known British feminist, wrote, "The sexual revolution wrought by feminist and gay activism has, of course, changed the political landscape in which trans people can live. It coexists with the commodification of gender archetypes and the reinstatement of seemingly polarized and parodic masculinities and femininities, caricatures. Any young person with problem in relation to their gender must be supported and helped to explore this situation, an approach that should avoid the damaging foreclosure which would be instantiated by saying, yes, you are a boy in the wrong body. Colluding with the delusion that biological sex can be altered is very dangerously misleading. One young woman told me that the clinician assessing her told her that she was right and that she was a candidate for transition. She was in the wrong body. She told me what she heard the clinician say was, I agree with you. Your female sexual body is a disgusting thing and we can get rid of it for you. Of course, it may be the case that certain young people will in the end undergo transition when adult. I'm arguing that no irreversible step be made until they have completed development. And even then, I think a responsible clinician would also in this situation be extremely cautious and advise careful, lengthy exploration before taking this step. First, do no harm. Thank you.
Caro Dr. Bell, muito obrigada por sua contribuição valiosíssima. O senhor está deixando questões em nosso país, não sei se está sendo traduzido para ele, de muito valor. Agora nós vamos escutar o Dr. Paulo Roberto Secarelli, que trará elementos para a nossa discussão, não é? Ele vai trazer as ideias dele sobre isso, e eu vou ler o currículo de Dr. Paulo Secarelli. Ele é psicólogo e psicanalista, doutor e pós-doutor pela Universidade de Paris 7, Diderot, membro da Sociedade de Psicanálise Freudiana, também em Paris. Sócio do Círculo Psicanalítico de Minas Gerais, sócio fundador do Círculo Psicanalítico do Pará, membro ativo do Espaço Brasileiro de Estudos Psicanalíticos, orientador de pesquisa e professor do mestrado profissional de promoção de saúde e prevenção da violência da Faculdade de Medicina da Universidade Federal de Minas Gerais, membro do corpo docente do contemporâneo Instituto de Psicanálise e Transdisciplinaridade, o POA, do Rio Grande do Sul, professor das especializações do Instituto SPRPE e coordenador de programas de formação livre. Também é coordenador do seminário Percurso, Grupo de Estudos e Formação em Psicanálise de Manaus, membro da Associação Universitária de Pesquisa em Psicopatologia Fundamental, membro do Programa Antártico Brasileiro. Dr. Secarelli também é autor de um livro que está na 4ª edição, Transsexualidades. Muito obrigada também, Dr. Secarelli, por estar conosco. A palavra é sua.
Boa noite a todos e a todas. Muito obrigado, Sandra, pela apresentação aí exaustiva do meu currículo, né? A gente tem, mas eu fico muito satisfeito com isso que você apresentou aí. E é um prazer, pena não estar pessoalmente. Eu estive aí no Recife há um ano, para o Congresso de Psicopatologia, uma cidade que eu já fui várias vezes, sou muito bem recebido, gosto muito daí, das pessoas, e é a primeira vez que eu estou participando aí desse grupo, através desse convite da Sandra. Então, é um prazer muito grande. Eu quero iniciar o que eu tenho a dizer, primeiro, cumprimentando o Dr. Bel pela excelente, não só a excelente exposição, como também pela fineza da observação, né? A observação psicanalítica que atravessa essa preocupação com o sujeito, que é bem diferente da preocupação médica, né, que a gente tem aí no que você apresentou, doutor Bel. E eu quero dizer, o meu doutorado, que eu fiz em Paris 7, como a Sandra falou, e foi exatamente nas transexualidades. Não tinha esse nome, esse é o nome do meu livro, né? O título da minha tese, que eu defendi no século passado, chamava Construção do Sentimento de Identidade Sexual no Transsexual. Porque a minha pergunta na época, a partir de que eu trabalhei, eu sou de Belo Horizonte, estou aqui, a partir de que eu trabalhava com os trans, me vinha essa pergunta, porque como que é que a gente sabe que a gente é menino ou menina, né? Então, o texto, doutor Belso, que o senhor apresentou, teve uma pitada de nostalgia, porque eu me vi enfrentando, através do seu texto, né, várias questões que eu tive que enfrentar quando eu estava fazendo o meu doutorado. Imagina, eu terminei a minha tese no fim de 1999, e as transexualidades, na época, era tida como... Não estou nem chegando ainda no que você está falando aí, desse ambulatório que tem na Tavistock Society. Eu fui na Tavistock, nós já conversamos sobre isso, conversei com o doutor Limentani, que trabalhava sobre esse tema, porque eu queria saber. Então, eu fiz a pesquisa central, foi em Paris, mas eu estive também em Nova York, em Amsterdã e na Tavistock Society, onde eu conversei com esse Limentani, que era referência na época. Nem sei se ele está vivo ainda, né? Mas foi um périplo no sentido de exatamente trazer isso que o Dr. Bel trouxe, né? Aonde que a psicanálise é e não é ouvida, né? É muito interessante essa apresentação do senhor, porque aqui em São Paulo, vocês devem saber, recentemente existia um laboratório desse no HC, eu conheço os responsáveis por esse ambulatório lá no Hospital das Clínicas, a grande referência no Brasil, e eu soube, falando o que eu li. Então, eu não sei, eu não me inteirei se isso é verdade. Que esse laboratório foi fechado por esses mesmos motivos que o Dr. Bell trouxe. Foi fechado por ordem do Ministério Público, que entendia que não tem como você, já entrando no âmago da questão que o Dr. Bell trouxe, como você pode acreditar, pensar, né, que uma criança de 5, 6, 7, 8 anos diga que eu não sou desse gênero. Né? Como esse caso que o Dr. Bell citou, essa menina que o irmão morreu e que ela tenta, numa uma tentativa, né, de ser amadas pelos pais, então é como se ela falasse, olha, não preocupa com a morte dele, não, que eu estou aqui. Eu estou aqui, eu posso substituí-lo. Isso eu tive em vários, que eu entrevistei, não sei quantos trans. Né? Isso não é trans. Né? Era uma pessoa que trazia essa sensação. Me lembro de uma pessoa, doutor Bels, que eu atingi aqui, que eu atendi em Paris, que ela falava, né, que a primeira vez que ela se transexualizou, não era o caso, já era adulta, nunca trabalhei com criança lá, foi quando ela se maquiou, era um menino, quando ele se maquiou no quarto da irmã que já tinha falecido, então usava as maquiagens. Né? Então, esse início, eu quis dizer porque o que o Dr. Bell falou foi muito atual dentro do que eu atravessei na França e continuo trabalhando com isso. Quando eu voltei da França, trabalhei no HC de São Paulo, foi quando abriu-se o ambulatório de transexualidades, hoje está com outra coisa. Mas o transexual, nessa época, era considerado ou psicótico, né, onde se viu pessoa com corpo normal, tudo normal, dizer que é mulher ou homem, ou então uma perversão ou uma falta de aceitação da homossexualidade. Todos esses casos existem. Né? Tem pessoa que, aquele presidente do Irã, quando ele falou que, acho que é Irã e Iraque, eu estou confundindo aqui, que naquele país não tinha homossexual, porque quando a pessoa era pega no ato homossexual, aquele que tinha o papel dito de passivo, automaticamente era operado. O Irã bate recorde, repito que eu não sei se é Irã ou Iraque, confundi aqui, bate o recorde em operações, porque é automático, né? Então não tem. Se você está gostando, você está no corpo errado. Então, é uma outra leitura. E nós passamos por essa situação aqui muito tempo, né? Quando eu trabalhei aqui em Belo Horizonte, no hospital, que hoje eu não trabalho mais com isso, no São José, é um hospital universitário aqui, também tinha várias pessoas que, ouvindo esse apelo do qual o Dr. Bell falou aí, procuravam o especialista em cirurgia, tá? Isso com o adulto. Agora, com a criança, coloca algumas questões muito interessantes que foram apresentadas aqui. Por exemplo, né, a primeira coisa que me veio ao ouvir o senhor é que o que a gente chama de identidade cis ou trans, né, eu não sei se em inglês é a mesma palavra, né? Cis é porque é a mesma, né? Eu sou homem, então é a minha identidade de homem. Trans é porque eu sou homem, mas é a minha identidade de mulher. Essa identidade cis ou trans, eu apresentei um texto que eu publiquei recentemente, que chama Transsexualismo, transexualidades, melhor, em mudanças discursivas, no qual eu trabalho esse tema. Né? Quer dizer, essa dúvida, eu sou homem ou mulher, eu gosto de homem ou de mulher, isso é uma dúvida comum no adolescente. O que a gente não tinha, por isso é que eu chamo de mudanças discursivas, era terminologia. Nós não tínhamos isso na minha juventude, essas dúvidas eram vividas em silêncio. Hoje nós temos uma oferta terminológica, que é o que o doutor Bel apontou muito bem aí, né? Que então a pessoa se identifica com aquilo, não quer dizer que ele seja aquilo. Então, a dúvida quanto à identidade cis ou trans, ela está presente em qualquer situação. Agora, o que acontece é que eu coloco a pergunta para os senhores, uma primeira pergunta. O que o senhor acha que acontece com os pais dessas crianças? É um alívio deles? Eu não tenho culpa? O que acontece que eles aceitam essa transição dos filhos, sabendo o perigo disso? Será que é uma maneira de dizer que é uma coisa que os transexuais gostam, né? Eu nasci assim, eu não tenho culpa do meu estado. Mas como que um pai aceita? Como que os pais aceitam? O que está aí, né? E outra coisa que o senhor mostra muito claro também é essa, me vi a palavra briga, eu acho que briga não é a palavra certa, né? Mas essa discordância entre o discurso médico tradicional, que a pessoa vai lá 5, 6 vezes já entra na fila, como era aqui, que não tem mais, né? E o discurso psicanalítico, que vê exatamente nesse período da puberdade toda a volta da sexualidade infantil. Isso aí está em Freud, né? A puberdade traz de volta a sexualidade infantil. E isso é completamente ignorado. Como que é possível se interromper a puberdade através de bloqueadores da puberdade para voltar lá na frente, né? É todo um período importantíssimo para a definição da identidade sexual e da orientação sexual que é negada à criança. Mas eu não quero me estender muito, eu tenho certeza que tem várias perguntas, mas eu gostaria de perguntar, doutor, vou repetir a pergunta, como o senhor entende, que posição é essa que os adultos acompanham, né? Os psicanalistas, como aqui tem pouco espaço de fala nesse espaço, até que venha uma lei e fecha o ambulatório, porque é impossível, né? O que é que esses pais, qual, na opinião do senhor, o que eles sentem, como que eles entendem para que eles permitam que os filhos passem por esse processo? Muito obrigado.
Thank you. Well, thanks for those comments. It prompts me to say, firstly, that one of Freud's most revolutionary positions, I won't say discovery, I'll say position, was in his attitude to sexuality. That is, sexuality was not a thing that you are, that you are gay, or that you are a man, or that you are a woman. It is a process, an unfolding, a development. So that positions one philosophically and clinically in a very different place. When, in the 3 essays, Freud is clear, you're not born heterosexual. You have to become one. And the same with being homosexual. You have to become. And of course, in Freud's time, the word gender didn't exist. But nevertheless, there's an implication that to become what, as he might have put it, culture calls a man, is a developmental process. So if someone says, if a man walks into a room and sits down and says, I'm a man, well, the right attitude would be, I wonder who I is who's making this assertion, and I wonder what he means by this word man, because I don't know. And a psychoanalyst has to be a kind of anthropologist, has to keep telling himself, I don't know, I don't understand, I need to have this explained to me by my patient. Whereas the anti-analytic attitude is, oh yes, you are a man or you are a woman, without any understanding about what that means. So it's a regression in thinking is what I'm saying. And I could say more of that about Freud, but I won't for the moment. But what you raise about parents, of course, there are many, many different clinical situations. Some parents are very opposed, and some parents support it, and some parents even suggest it to the child. Now, as one a colleague is in fact a sociologist who's been interested in this for a long time, put it to me. And when he put it this way, it's very obvious, isn't it? He said, if you're a parent and you've got a child who has a mental disorder, is disturbed, it's hard to think of anything that can make you feel worse. in terms of guilt, because you must be involved in some way. It's not possible that you're not. And you have to face this every day. And it's terrible for parents to face this. So for some parents, when the child says, I'm trans, and the clinician says, yes, your daughter is really, all their problems are caused by their being born in the wrong body, it'd be natural to be relieved. You know, it's not that I've done something terrible. It's a clinical condition. The doctors told me it's like a physical condition. So what I must do now is help my child and join the campaign for the child to be changed so that they'll be happy. And if a parent gets into that position, which I personally have a lot of sympathy for and can understand, then if the child changes their mind or the clinician changes their mind, the parent will resist it. I've heard of a parent, the clinician, saying, I don't think gender is a problem with your child. I think it's something else that we need to explore. And the parent taking the child away to another clinician because that was too difficult a problem. And then there's a different kind of situation in which families, for example, in which the mother has very complicated feelings about her own sexuality. Say a mother who might have been abused as a child. Then she sees her daughter developing sexual characteristics, and she's filled with anxiety and disgust. And the child picks this up, that there's something terrible about their body. So the child then internalizes the mother's hatred of their body and knows that they will be relieved and their mother will be relieved if they can get rid of these breasts. So there are many, many different, and probably many other different kinds of parent engagement. And there's a group, a significant group, maybe not a large group, of very disturbed parents. And for them, it becomes a little bit like Munchausen syndrome, Munchausen's by proxy, that they almost molding their child into having this kind of disorder because of their own difficulties. I don't think that's common, but it occurs. So there are many, many different scenarios. The other thing you talked about is what I alluded to how can we understand this breaking with a proper psychoanalytic attitude? Now, when I say a proper psychoanalytic attitude, I could say that in the United Kingdom, my psychoanalytic colleagues largely supported the position that I took. Some of them quite quietly, but nevertheless they agreed. Completely different in the States, where large portions of the psychoanalytic movement are in favor of affirmation, which is not only an anti-psychoanalytic attitude, it's an anti-clinical attitude for any clinician involved. When I was describing this to some people in government, they asked me about this, and I said, if a person comes to me and says to me, I hate my wife and I want to get divorced, I do not affirm the person. I don't, oh, right, we'll help you get a divorce. I think, I don't know why they've come to see me. I don't know why there's that urgency in their voice. I don't know who their wife is. I don't know why they hate them. I don't know what this particular hatred means in the life of this human being who's in front of me. And most certainly, I do not know what divorce means. So I show the person I've understood what they've said, and then I wait to understand what it all means, which may take time. And most ordinary MPs, ordinary members of parliament, they weren't clinicians, they weren't psychoanalysts, but they thought that was common sense. Why would you agree with someone straight away when you know nothing about them? So it's a most peculiar thing, this pressure to give up a kind of clinical detachment. You wouldn't say to an anorexic girl, yes, you're right, 5 stone is the right weight for you. You might not say 5 stone is the wrong weight, but you might want to understand what it means to have to be so small. So maybe, I know I'm just looking at time and I'm just wondering whether we ought also to bring in some of the audience. I know some people have put things in the chat. Obviously, I understand them to some extent, in Portuguese, but not necessarily completely. What do you think, Paulo? Or do you want to carry on our conversation?
Não, eu gostaria de conversar o resto do dia, né? Porque é muito interessante, é a área que eu trabalho também. Acho, contudo, que não é simples, né? O pai ele quer adaptar o filho, afinal de contas o filho está sofrendo, mas não é uma coisa simples. Igual a gente não adapta uma neurose, igual a gente não fala para um pai, não, preocupa não, seu filho é neurótico, mas esse é assim mesmo, né? Então, eu acho que é uma coisa que tem a ver, como foi frisado aqui, com a sexualidade dos pais, claro, como é que eles vivem a sexualidade deles. Aquele filho pode ser uma resposta, dizer que não é culpa dele, mas tem o problema social e mostra perfeitamente aí, quando fala dos Estados Unidos, né, a psicanálise dos Estados Unidos não chegou direito, né? O próprio Freud fala isso. Então, a linha de pensamento deles, eu não sei se eles são antipsicanalistas, eles trabalham muito mais com a comportamental. Então, é aquilo mesmo, você gênero, quando começou as primeiras operações nesse sentido, né, que foi na universidade lá, aquela mais famosa dos Estados Unidos, né, da John Hopkins, o formulário que a pessoa tinha que preencher nos anos 50 para saber se era trans ou não, a maioria das mulheres seguramente tomariam bomba, porque é um modelo comportamental de ser mulher, é ficar em casa, é cuidar do marido, é cuidar dos filhos. Esses sim eram operados, né? Então tem algo aí do pensamento social que atua aí. E a psicanálise tem uma outra proposta, né? Mas eu não quero continuar aqui, senão vai longe. Agradeço mais uma vez. Eu tenho certeza, a Sandra, né? Mas eu tenho certeza que tem muita gente aí querendo falar, eu não vou monopolizar. Agradeço e espero ter oportunidade de a gente conversar mais, não só com o senhor, como com a sociedade toda aí. Muito obrigado, Sandra.
Nós é que lhe agradecemos, Secarelli. Muito obrigado pela interação
Obrigado.
e pelo
Obrigado.
enriquecimento. Eu acho que a gente... Doutor Bel, eu acho que a gente pode abrir para uma pergunta na plateia, pode ser?
Boa tarde, Eliane, da SPFOD, Fortaleza. Eu gostaria de ouvir o doutor Bel e o Paulo a respeito dessa mudança, né, da casuística, porque antigamente o Stoller trabalhou com isso, né, era praticamente todos os casos era da transexualidade, como a gente fala hoje, a transexualidade feminina, ou seja, né, partindo do sexo masculino, se tornando uma mulher. E hoje, o doutor Bel falou para nós aí no começo, né, mais de 70% dos casos, se eu entendi bem, eram de meninas querendo se tornar meninos, né, ou se considerando meninos. Eu tive um caso no meu consultório, e nitidamente era uma necessidade de defesa. A menina se achava assim, era um pavor quase que atávico de ser penetrada, de ser invadida, de ser agredida pelos homens, né? Todo homem era um agressor em potencial. Fico pensando também se não é uma nova forma de inveja do pênis. Então eu gostaria de ouvi-los a respeito disso. Obrigada.
Well, I think there's two things. One is slightly still talking about Paolo and something of what you've said in referring to Stoller. I think it might be important to say that the situations I'm talking about are children. I'm not talking about adults. And I think, although certain of the psychological understandings are relevant, our ethical position is different. So we have a responsibility to a child. And this pushing of a child into treatment that we know causes damage for a problem that hasn't been understood, it's caused, I say, a lot of damage. When it comes to adults, I think the situation is different. But again, as I said at the end of my paper, any clinician who had an adult come and say, I'm a woman and I want to have the surgery, and within a few weeks puts the person on their waiting list, to me, that person is a completely unethical, irresponsible clinician. Even though the person is an adult, they should be engaged in some long-term understanding before taking any action. And one worries about the amount of money that's being made out of this huge growth of this new industry. So, but when it comes to the change there are two changes. One is that so many of them are adolescent. They present for the first time as adolescent. So you don't have to be a great clinician to think this must be a presentation of an adolescent crisis. And it's being presented in the chameleon, the changing cultural color that is the context of the world that we're in. So this should be a child who's in an adolescent crisis, and we need to understand it. Now, why? Why do so many girls claim that they're boys? It is sometimes said that some of these children, that they say, I'm in the wrong body, I'm really a man. Most of them, in fact, don't say it like that. They don't say it as calmly as that. They say, I hate this body. It's not what I want to be, it's what I want to get out of, what I want to get rid of. This filthy, disgusting. I knew of a girl, she wouldn't even use the word breast. She would threaten the clinician. If she used the word breast, she would leave the room. So, but why this huge change? And I think there are many reasons, but one of them is, I think, a kind of subtle misogyny, and sometimes not so subtle. So, for example, some of the trans lobbies try to pressure doctors and clinicians and so on not to say a person is a woman, but to say she is a person with breasts and ovaries, as if the female body can be cut up into bits, and you can be a person with breasts and a person with ovaries and a person with a vagina or a person with a penis. And I think this cutting up of the female body into parts that can be removed and replaced, I think is a kind of expression of a deep cultural violent misogyny. And I think another expression of this misogyny is a kind of liberalization of pornography. So what people are, when I was a young medical student and doctor, I was part of the 60s, so we were very fighting for homosexual rights, fighting for the non-medicalization of homosexuality, not seeing it as an illness. And also, women's liberation was so much part of our world. And for the first time, women were saying, it's my body, it's my sexuality, and I'll say what I like, and what I don't like, and what I don't want. And I think that's changed, and I don't know about in Brazil, but I've heard from many young women that online, the pornography takes such a grip, and they start to feel that they have to do these things. And the boys tell them, look at this on the film, I have to violently penetrate you from the bottom. I have to force my penis into your mouth. And you're supposed to give in. And a lot of girls get terribly frightened. And unless they're protected and helped, this accelerates their fear, their ordinary fear about their sexual body. So I think that the women's, it's what Bay Campbell was saying at the end. There's been this caricaturistic attack upon femininity. There's a kind of binary that girls are girly girls and boys and masculine boys. So I think these are all very subtle and not so subtle, misogynistic aspects of our culture, which I think affect young girls very deeply and they need a lot of help with. So I think that's another reason. And I think another reason is to do with the more general thing, is to do with the commodification. The body is seen as a kind of commodity that is not something in a sense that you have to painfully tolerate, but that can be exchanged. And that gets into the culture too. But I think the big question, why does it go from 45% girls to 85%? And why are all these girls saying, I can't stand my female body? That's a psychological, it's a cultural and a sociological question that we can have some theories about, but we need some research on to answer. But you can't do research on it in a world in which that way of thinking isn't being acknowledged. The Tavistock, which is one of the world leaders of thinking about the individual, the family, and the culture. Why is it that no one at the Tavistock was saying, this is an interesting sociological phenomenon, let's just stop these treatments and try and work out what's going on culturally, sociologically, for all these girls suddenly coming forward saying they hate their bodies? So it's a very important question, and I can't say I know all the answers, but I made some suggestions.
Eu não sei se a gente tem mais uma pergunta aqui, ou se a gente perguntaria... Sim, por favor, tem uma pessoa que quer fazer uma pergunta. Pois não.
Boa tarde, meu nome é Jorge, sou estudante de psicanálise e de psicologia. Eu queria perguntar ao Dr. David Bell. Eu estava refletindo aqui. Primeiro, muito obrigado por compartilhar seu conhecimento conosco. Acho que foi muito esclarecedor vários pontos aqui para mim, né? Inclusive da questão de não cometer o mesmo erro com os homossexuais, com os transgêneros, né? Acho muito importante essa reflexão para não se tornar uma coisa somente automática, né? E aí, o segundo ponto que me veio à mente é que nos inícios dos meus estudos sobre Freud, eu entendi o quão importante era que o indivíduo, né, que o queixoso, o analisando, tivesse a fala, né, para a partir dali, da fala do paciente, pudesse surgir as soluções, né, daquilo que estava sendo tratado, analisado, né? E depois, durante o século XX, né, falando da homossexualidade, a gente teve algumas figuras como, se eu não me engano, Ernest Jones, que não validava psicanalistas homossexuais, né, para serem psicanalistas, porque ele achava que, se eu não estiver errando a pessoa, né, que o homossexual não poderia ser psicanalista porque tinha uma doença que não queria se curar, né? E aí, tendo isso em vista, eu acho que talvez fosse importante, eu não sei se isso já existe hoje ou não, a inclusão de transgêneros dentro da psicanálise para ajudar na condução desses estudos, que eu acho importantíssimo, né? Para ajudar a responder essas perguntas. Porque, só repetindo, acho tudo muito esclarecedor e muito válido, tudo que foi exposto e dito, né? Mas, de repente, tendo a visão de alguém que tem os estudos da psicanálise e seja um transgênero, talvez contribuísse um pouco. Existe isso atualmente, não?
Well, I think what you say about homosexuality is very important, first of all. And that is that, at least from the... Pardon? Is it okay for me to continue?
Yes, you can go.
So I think it took a long time for large parts of the world to catch up with Freud. So that if you read the 3 essays carefully, you will see that Freud, he doesn't talk about homosexuality per se. He talks about homosexualities. So a man identified with a woman, who might take a man identified with a woman, or a man identified with a man, various complex identifications that interested him. And he often uses the term so-called abnormal. In other words, how we decide what normal and abnormal is more a kind of cultural question than a psychoanalytic question. And he famously answered a mother who wrote to him saying that she wanted him to treat her homosexual son, saying that he would, if possible, if the son wanted treatment, he could have treatment. And he said, he spent a long time in the letter saying, you should not be ashamed of your son's homosexuality. There's nothing to be ashamed of. Some of our greatest, contributors to humanity have been homosexual and so on. And they should be free. But he said, if the son is neurotic, then he could treat him. And it could be that his homosexuality has some neurotic aspect, in which case it may be that he would change. But more likely is that if the homosexuality doesn't have any particular neurotic aspect, treating him would help him become a happier homosexual. So that was a very kind of revolutionary attitude. And also he was once asked by Ernest Jones, the Dutch Society wanted to know if a homosexual man could become an analyst. And they said no. And Freud disagreed. So why should we line up with this kind of bourgeois prejudice? We should judge the man on other capacities, on his capacities, not on whether he's homosexual or not. So it took a long time for the world to catch up. And particularly, I think, in those parts of the world where doctors possess psychoanalysis, it started to have the quality of a mental hygiene movement. I think we even have a problem when we say, what trans and can trans people help us? Because there we make a kind of homogenous group. There isn't such a thing. For instance, women who transition to men are quite different to men who transition to women. And then amongst women who transition to women, there are differences in sexuality, difference in the pathway that led them to it. So I think we have a problem if we say there is something called trans and we need to see what the cause is. It's a cultural expression that, particularly in children and adolescents, that's become much more frequent and we need to understand. As regards the issue of whether a trans person could be a psychoanalyst, I think I would take the same attitude as Freud. That is, if they applied, they should be thought about in the same way as one would think about anyone else, to see whether they got the capacity to think about themselves in a thoroughgoing way, to understand themselves and to think about those around them. And if they have, I don't see why they shouldn't be a psychoanalyst.
Dr. Bell,
any such person, say a trans analyst, encouraging a young person who says I'm trans to become trans. That would be in the same way with homosexuality. One of the big differences with homosexuality is we have a movement in Britain called the lesbian, gay and bisexuals. They left the trans movement because they didn't agree with them at all because of they thought they were damaging gay and lesbian, potentially gay and lesbian children. But what was I going to say? Yes, one of the things they point out is that gay men, remember we talked about that because in England it was illegal to be homosexual. It wasn't illegal to be lesbian ever, but it's illegal to be homosexual. So they would say that gay men are not asking to have surgical and medical treatment to be gay. They're asking to be left alone and not interfered with by doctors who tell them they've got a disease. That's their right. And of course, that's right that I and many others supported. Whereas with the trans movement, there's a demand that, that these children are medicalized and have their development interfered with and parts of their bodies removed. That's very, very different. So these things are different. I'm just looking at the time, in terms of how we can manage.
Muitíssimo grata por sua contribuição. Estamos todos gratos. Vamos aplaudir, não é, Dr. Bell?